going to go through these slides in the order that I have. If there's any standout questions, feel free to stop and ask me about that. If it can wait till the end, we will have a question and answer period as we go. So, and at the end as well. So don't worry about that. We will get to everybody's questions and answers. Good morning, Young Soon. Okay, so let's go back here. Today's agenda, we're going to talk about PICC lines, portacaths, peripheral IV lines, and midlines. Then we're going to review some of our protocols that we all know, but we may have forgotten some tips. And line issues, how to troubleshoot. And then, of course, like I always like to do, is go through some scenarios. Okay, and when we go through the scenarios, just know that I take these scenarios that I present from real life issues that we've been getting here in this agency, or maybe some of my other agencies I've worked in the past. And I also sometimes change it up. So if something doesn't sound quite like the scenario that you dealt with, if it's one of your scenarios, that's okay. I do sometimes change it up and maybe include two issues at the same time. So first we're going to look at PICC dressings, and I'm going to play this video for us to watch. Can everybody hear the sound?
Yes.
Okay. Whoops. Okay, so I want to point out a few things. First of all, notice how gently that dressing was taken off. It wasn't pulled dry. Use either the ChloraPrep or an alcohol or the adhesive remover if you have any of those packets. Make sure you're loosening that glue gently from the patient because it can be extremely irritating to a patient. And also you don't want to tug it without being that gentle because you don't want to pull that line out. So this video also showed that the PICC line was taped down so it doesn't make any tugging movements as well. That's always a good thing to do. So of course, if you don't have 2 pairs of sterile gloves, you're going to use the clean gloves first and then your sterile gloves. This is pretty self-explanatory, just as we went through with the video. So just go ahead and read these steps as we go along. And it's really a very good idea to loosen it first, go very slowly, go very gently, and pull up rather than down, because tugging that tegaderm down will also increase the chance that you're pulling out that line. But when you go upwards, there's a better chance because of that stat lock that you will not dislodge that line. So please make sure that we're doing that on every patient. Once the tegaderm is in place, make sure it's taped down in a very convenient place for the patient. You know, sometimes we can move it to the left or to the right, slightly to the side if it gets in the bend of the arm. We just want to make sure that the patient is going to be comfortable when we put that down in place. And of course, the clave connectors are changed weekly with that dressing change. In case we do have to do any measurements, which we should do on the first visit, and we should really do on every visit, but sometimes we just know everything looks great, especially if the patient's super thin, they're not getting a lot of fluids, and but here's a technique that would just help.
I'm just making this quick video so we can go over how to properly measure.
Perfect. Thank you. Okay. Awesome.
Of an arm. This is just an example. This is not a PICC line, but we're going to be using this as a reference.
And this is Mercedes, your on-call scheduler for Bucasol.
So in standard in every kit, you're always going to have a measuring tape. On one side, you're going to see the larger numbers, which are the inches. On the other side, you're going to see the centimeters. We always measure in centimeters. Medicine is metric. Remember that. Medicine is metric. So once you have your perfectly dressed PICC line, your first order of business is measuring your external, your circumference. At which point you can either go from the antecubital up 10 centimeters and measure, thusly. So this gives me a reading of 28 centimeters. Let's do that again. 28 centimeters, 10 centimeters from the antecubital. Or you can do 4 centimeters from the entry point and do the same thing. You pick a site, you pick a method, and you stay consistent with that
Sorry, somebody else is just joining. Okay.
method. Personally, I'm very big on the 10 centimeters up and around. Okay? That is the circumference of an arm using your centimeters. Now, the second order of business, our documentation asks us to document the external length of a catheter. Most of our catheters have these marcations on them, each line measuring a centimeter. Once again, medicine is metric. So if you look carefully, you're going to see 1, 2, 3 markings on this example. You can either choose to use this as a reference and measure up, or you can count. You don't want to ever count when your line is exposed. You only do this once your dressing is on, whether it's clean or whether it's dirty. Hopefully, you do it after you clean it. That way you have a good sense of where it is ending. If you have any questions, feel free to call me or text me or email me.
One thing I want to add, document the brand name of your line. It's either going to be on the wing part, and if it's not here, like this one does not say, it will be on the actual line. This is an Arrow Endurance. And that's it.
Okay, and it's important to measure just to make sure we're not having any infiltrations or any swelling from any other reasons for this patient.
Great job, guys.
Okay, so now for the PICC dressing change, here's where I want us to have interactions. I'd like to get some feedback from you guys. So what is the best practice steps to take to attach and to snap the stat lock? Anybody want to jump in here? Anybody?
Tell the patient to stay still.
Yes, but again, just like it showed in the video, you want to snap the line in before you attach it to the patient. Because what happens is if you stick that glue end onto the patient's arm, then you've got to press really tight to snap the line into that stat lock once it's already glued into the arm. And you really want to avoid putting that kind of pressure pushing into the arm. So snap it between your fingers and then you can glue it down to the patient. Make sense?
Yes.
Yes.
Okay, what is best practice protocol if the insertion site is irritated, inflamed, or blistered? Anybody just jump in?
Okay.
You know, Susan, we get this a lot. We have a lot
Yes.
of calls from nurses saying that the patient is reacting to the tegaderm or the site is blistered and all that. So I'm glad we're tackling this.
Absolutely. So one thing we want to make sure of is what exactly is the patient reacting to? It can be the tegaderm, but before we change the tegaderm, first and foremost, we have to report this because the agency needs to know, the pharmacy needs to know, the doctor needs to know. It could be a reaction to the medication. It could be a reaction to the ChloraPrep prep, in which case we'd have to switch to alcohol and the povidone iodine. Which we prefer the ChloraPrep, but sometimes we do have to switch. So we want to try to eliminate what it might be before we automatically just send for a new tegaderm, because that may or may not relieve the issue. We really want to make sure that it's not an infiltration, it's not an extravasation, and we're going to go into that in a little bit on the slide. Or that the patient is irritated from the medicine. Usually if that's the case, it's not just on the site of the insertion or under the tegaderm. Usually a medication reaction will be more widespread, more systemic. But definitely photograph and document and report anything that you're seeing, and then we'll take the steps to see what the issue might be.
Susan, there's someone in the waiting room.
I only have that one person that's the icon. Do you want me to do the
Okay, yeah, that's Marivi. Yeah.
Oh, okay. Perfect.
Okay.
Got it. Okay, if the line is tugged out a bit, does anybody know what the protocol would be? Anybody. Okay, so we can tug, if it tugs for any reason, we want to document and we want to report. We want to make sure there's still a blood return. We want to make sure it's still infusing without any pain or irritation to the patient. But if it's more than 2 centimeters pulled out, we are not going to infuse the medication because they have to go now to check for placement and make sure it didn't pull out too far from where the insertion site is. So just make sure you're measuring and documenting. And then we also have to do a bit of teaching and training for the patient or the caregiver, whoever's taking care of this IV infusion, because obviously there's some tugging going on. So now, do they have a child? Do they have a pet they're taking care of that's jumping on them? Do we have to tape it down and secure it a little better? So we want to really find out why it's being tugged. Did it happen on the last dressing change? If it did, then that nurse would have documented it, and we just have to check with the office. So there are a lot of things we really need to do, keep the checks and balances going. Okay, if the line is clogged, what are some steps we might be able to take? Anybody at all?
We call, I think there's a
Yes.
order, get the declot, or if they decided to go that way, so. Yeah.
Yes, but that's not the first thing we do. That's the last thing we do. The first thing we do is try to flush it several times with a heparin syringe, because sometimes if there is a clot forming, we can declot it just with 1 or 2 heparin syringes. So we try that first. We try repositioning it. We try to see what is going on. Sometimes we won't get a blood return, but we can still flush. That happens usually when the PICC line is a little bit older. It's like a used straw. Sometimes you can't suck in, but you can blow bubbles. Same thing with your veins. Sometimes that PICC line just gets a little bit worn if it's been used for quite a while. So we still might be able to infuse, we just may not get a blood return. So before we order any of the TPN type of products, the CathFlow or anything like that, we do want to make sure we've tried everything else, repositioning, heparin, before we get a doctor's order. But yes, those are the steps. If the tegaderm's been lifted all around.
Susan, one moment, sorry.
Absolutely.
We've had instances where the nurse reports that the line is not flushing, or a patient calls saying that the line is not flushing.
Mhm.
And we order CathFlow only to find out that there was a kink in the line.
Correct.
So all the nurse had to do was to change the dressing and open the dressing and see if there's a kink, and then redress it. Right. So we've had that instance
Absolutely.
also before.
We have had that several times that I know of even, and I know I haven't even been told about all of them. So yes, so reposition that line, make sure it's not twisted inside the patient's arm. And when we get to a couple of the photos later, I will show you how a line can get kinked and twisted like that. So just be aware of all the other steps that we do need to take first to just make it easier on us. Otherwise, the CathFlow won't even work if it was some other issue. Okay, when tegaderm gets lifted all around and the insertion site is exposed, what are some of the things that we can do?
Can
We have a,
The
yeah,
question,
go ahead.
can you repeat that question?
Oh, repeat the question. Yes, if you can see my screen, you should be able to see my screen. It's on here. What is the best practice if the tegaderm has been lifted all around and the insertion site is exposed? So first and foremost, we want to change that dressing. We want to make sure that the patient has been taught and trained how to maintain that area, that site of infusion. Maybe they took a shower and forgot to put on the sleeve that the pharmacies can send to protect that site from getting wet and lifting. Because once that tegaderm lifts and the insertion site is exposed, that area is no longer sterile. And that really could be a very important concern. Generally, people have a PICC line when they need long-term antibiotics. So if they're already dealing with an infection, we don't want to add to the problem by having anything exposed that could increase or add a new infection going on. So make sure we change it, and then make sure we do teaching and training for the patient and or the caregivers that are caring for that patient. So we already spoke about exposing the PICC line. After 2 centimeters, we've got to have the patient go and check for placement through ultrasound, because more than 2 centimeters pulled out, chances are they're going to need a new PICC line put in. Any questions?
No.
Okay. All right, thank you. So when we're doing some teaching and training, we
I have a question.
absolutely.
Yes. Sometimes, let's say in the evening, we get a call from the patient saying, "Hey, I need a PICC dressing change. I just
Mhm,
took a shower and my dressing is coming off, or I'm sweating and my dressing is coming off."
mhm.
And then we may not be able to get a nurse to go right away. In that case, what's the best practice?
Best practice is to find out from the patient, hopefully they can send us a picture, how much it's coming off and exposed. Because if that site is completely exposed, if we can't get a nurse out there, they'll have to go to the ER and take care of that. If it's not exposed, if the dressing is just a little bit loose because they got it wet, then we can teach the patient how to tape it back down and make sure that it's not going to expose that site. So they can first put tape around the tegaderm and then put that mesh sleeve on top so that it really stays in place. So securing it until we can get a nurse is critical.
Sounds good.
How about with the double lumen, when one of them is clogged and you're unable to unclog it, but you use the other one? Is
Mhm.
there anything you need to report about that, as far as, you continue to use the one remaining line?
Yes. So first of all, usually the reason one line gets clogged and not the other is because sometimes the nurses forget to show the patient or have them return demo the fact that they were supposed to flush both lines and not just the one that they're using for the IV infusions. So even though we're only using the one line maybe for lab draws, that patient does need to, on a daily basis, flush it with saline and heparin. And that's going to prevent it from happening. Now, if it does happen, we do report it. Even though there's one line working and we're going to keep using the one line, we do want to report it to the pharmacy. And we do want to try to do the unclogs again with the heparin, 1 or 2 syringes. If that doesn't work, we don't necessarily need the cath flow right away if we're able to still use the second line. But if we have to use 2 lines, sometimes the patient has 2 IVs going at the same time. And I've seen that many, many times. Then we do have to probably do the cath flow or send them to get that changed. Does that answer your question?
Yes.
Okay. So we want to make sure we're teaching the patient and we're not just showing them, but we're telling them, and then we're having them repeat the process. So what I like to do is teach them how to take the air out of the saline syringe and then push up and then twist and turn. And then I'll say, now you do it. And I'll have that patient do that. One of the biggest issues that we get the most calls on is the patient was told what to do or shown to watch what to do, but they weren't given the opportunity to return demonstrate what to do. And then the patient's left on their own and really has no idea. So the return demo is absolutely critical from the minute you step foot into that patient's home on the first visit. Don't wait for the second or third visit and assume you're going to go back, because a lot of times the nurses start a case. They don't have time that they'd like to spend doing the return demo. So they say, I'll teach you more tomorrow. And then tomorrow comes and the nurse isn't available. So please make sure you're doing that. So you teach them how to prepare the flush, how to use the alcohol swabs properly, how to use those Curos caps. Now, not everybody gets them. Not every pharmacy sends them. But if they do have them, teach them how to use those. The safety clasps are important because a lot of times the patient thinks that the IV is not working, but that's because you may have clamped it before you left, and now they don't know how to unclamp it when they have to go to do that first infusion. Teach the patient how to check for placement before they're doing any IV medications. Teach them the SASH protocol, the pump connections to the IV line, how to connect it properly, how to troubleshoot the pump. This is critical for, whoever's got noise in the background, can you just mute yourself? Thank you. Okay, it's very, very important to teach the patient what the pump might beep for. What are the reasons it might beep? And teach them what to do in case the pump beeps. Teach them when they start or change an IV bag, the difference between resume and repeat, because that causes a lot of issues with our patients. And to pause it if they need to disconnect for any reasons, and how to take care of the end of that line if they are disconnecting for any temporary reason. So please make sure on your first start of care, you're teaching your patient all of this. How to shower with a PICC line and a pump, how to take care of that, and answering all their questions and concerns that the patient may have. Make sure before you leave that they completely understand what to do now that you're leaving and won't be back for a week, most times. And also, most importantly, I get the most calls over a patient's first independent infusion because, again, like I had said, they may have been shown what to do, but they never did it. Or they may have been told by the nurse, watch what I do and do this tomorrow. And now here they are and they forgot every step. So please make sure you do the return demo. And if the patient does need to take any notes, let them take notes as you're going. And most importantly, even though you may not be going back that next day, which would be their first independent infusion, please make sure you're available to them by phone. If you say, well, you're due tomorrow morning at 9 a.m., if you need me to walk you through it on the phone, I'll do that. And please make sure to be available, because the most calls we get, from what I know in the office, is patients on their first visit or their first independent administration. They just don't know how to do. They don't remember the steps, or they can't do the steps. So please just be available. It would take you 5 minutes to walk them through instead of them trying for several hours and then calling the office trying to reach you, the office then trying to reach me, then me getting back to the patient. Now they've missed 1 or 2 infusions. So please make sure, whether it is a PICC line, a port, a midline, or a peripheral, just let the patient know you will be available for that 5 minutes to just help them connect and get the medicine and the pump working for them. It really goes a long way for customer service. Anybody have any questions about that? Okay, and of course, it eases up a lot of their frustration and anguish thinking about doing it themselves.
I have a question, Susan.
Yeah, sure.
Option Care
Yes.
has informed us that they will not be supplying green caps, gloves, and BioPatch to all patients, with the exception of patients that are immunocompromised.
Mhm.
Now, every now and then we get nurses calling for the green caps, or we get patients requesting for gloves and all, and we contact them and they still said they are not. Now, they want the nurses to train the patient to thoroughly wash their hands before doing their infusion, and also to scrub the connector cap pretty well.
Yes.
Right. So in such cases, can you enlighten us more on alternatives?
Yes, so let's talk about the Kuros caps first. All that is a little cap filled with a little piece of gauze that's drenched in alcohol that keeps the end of your line sterile. When the pharmacy does not send the Kuros caps, all you have to do is teach the patient how to scrub really good, at least 15 to 30 seconds with the alcohol swab around the end of that clave connector. And that takes care of any issues from the line, any bacteria that might have gotten on there, any other germs in any way. You just want to make sure you're scrubbing. Now, what I tell my patients is, if they have to temporarily disconnect, maybe they're on a 24-hour bag and the infusions go every 6 hours, but they want to disconnect, take a shower, do whatever, or shop and do what they have to do. I will tell them to take the end of that IV line, not the end of their PICC line, but the end of the IV line from the medication. And since there might not be a cap on that end, stick that end into an opened alcohol swab little container, give that little 2x2, and tighten that and just kind of leave it sitting in the alcohol pad. That way, when they reconnect, you still have to scrub the end of your clave connector with alcohol, but the end of the IV line itself is staying sterile inside that alcohol pad. Does that make sense for everybody?
Yes, I've done that before.
Perfect. Yeah, so yes, Cures caps are not mandatory anymore. A lot of pharmacies stopped sending them. Now, with the biopatches, I have heard that from numerous agencies. A lot of them are no longer sending biopatches routinely. So we just have to make sure that we're keeping that site as sterile as we can. And if the patient is immunocompromised that you know and the pharmacy missed it, you can request it, but they still may not send it. So it really is up to the pharmacy. If that's missing, just reach out to them, reach out to the agency first. They will reach out to the pharmacy and see if it's something they forgot to send or if they are not sending it with this patient. But do ask about it. Okay. We will talk further in a little bit about if there's a gap. Sometimes that biopatch can fill in the gap, especially on a portacath, and we're going to talk about that in a minute. So if there's no biopatch, but there's a gap between the skin and the end of that Huber needle, you can fill it in with a small piece of gauze, or sometimes they send the Telfa pad, the non-stick, that you can put under that spot to kind of fill in that gap. And that's only if there's a gap or if there's no biopatch.
I'm sorry, I have a question.
Yes.
Going back to the tubing. So
Yes.
should I, sometimes I use, if I don't have anything and they have pets at home and things like that, if I don't have enough alcohol pads, should I stop telling them to do this? I use the capping from the cap from the saline or the heparin to screw it on, because it's still pretty clean and sterile when you remove it from the package. I stick it to the end of the tubing.
Sure, you can do that. It's not absolutely necessary, but it's definitely something you can do.
Okay.
Perfect, thank you.
Mm-hmm.
All right, let's talk about portacaths now. And we're going to watch a little video on this. I know probably most of you are pros at this already. There are just a few things that I do want to point out either as we go or after this plays.
Perform hand hygiene. Open sterile dressing tray. Don mask. Add required equipment. Don sterile gloves. Prime injection cap with sterile 10 milliliter syringe. Attach prime injection cap to non-coring Huber power lock needle and flush. Place back on sterile field. Palpate and stabilize the IVAD with non-dominant hand.
Okay, just want to mention one thing here. She's already got her sterile gloves on and she's already touching the patient, but she's going to come back and now touch some of her supplies. Please get your markings before you put on your sterile gloves to know where that port is in place, okay?
Note, this hand is no longer sterile. Cleanse the injection site with the SoluPrep using back and forth friction. Cleanse the area larger than the size of the dressing. Allow 30 seconds to dry. Insert the non-coring Huber Powerlock needle at a 90-degree angle. Check for blood return. If present, flush with 20 mL of normal saline. Non-coring Huber Powerlock needle is going to be attached to an IV. Ensure you have all equipment ready. If no IV is infusing, heparinize the line with 5 milliliters using 2 3 ml pre-filled hepaline syringes. Apply Tegaderm IV Advance 1685. And doff gloves. Perform hand hygiene. Ensure you have performed hand hygiene. Don clean gloves. Remove dressing.
Here's where those alcohols or tape removers, adhesive removers do work. Please don't just peel like this.
Stabilize the access device with fingers of the non-dominant hand. Remove non-coring Powerlock needle until you hear a click. Apply adhesive bandage if needed. Doff gloves and perform hand hygiene.
Okay, so one thing that I've run across is most of the time you do leave this Huber needle hanging down and you can access it from under the shirt or on top of the shirt. But when the dressing's in place, a lot of times you may come across a patient that wants it turning up so that you can just work from the top, from their neckline, and you don't have to fish underneath their shirt. So just ask the patient what their preference is. If they want it coming out, then you're going to tape it coming out their collar. And believe it or not, there are patients that do prefer that. So you are going to check the area for your landmarks before you put on your sterile gloves, so that you're not going in and touching the sterile equipment with the hand that is no longer sterile, like she did on this video. You are going to make sure that you do not touch anything. The one thing that I've come across this numerous times when I'm teaching and training or just going to supervise a patient, I see that people are removing everything from the package, from that sterile package, before they even have their sterile gloves on and trying to connect everything. Please, 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 please don't do that, because now nothing is left sterile in that kit. You want to gently, with 2 fingers, take out the mask, take out the dressing pad, the little towel that they send in. Nothing else should be touched until your sterile gloves are on. You want to make sure that the patient, as well as you, both put the mask on. You want to make sure that you are anchoring the skin on accessing the port and anchoring that skin and that port on de-accessing that area. Because if you're tugging, but you're not holding down that port, it actually is very painful to the patient. You're actually moving it and pulling and tugging on it, and it can actually cause quite a bit of pain. So please make sure that you're anchoring both times. Again, with the BioPatch, it should be there. If it's not, reported, the pharmacy may or may not send a BioPatch again. And when you cover it with Tegaderm, make sure that the patient, if it's a change and not the first time, make sure that they're not irritated. Make sure there's no markings at all. If it's somebody that does sweat a lot, we want to make sure to really stabilize that okay. We want to make sure that the ChloraPrep has dried completely before putting on that dressing. And again, ask the patient if they do have a preference for the direction that the dressing is facing. Some like it further up, some like it further down. Again, it also depends on where the port is placed, but just make it comfortable for that patient. Okay, so if we get no blood return when we're doing a port access, what are some of the best practice protocols that we can take? Somebody can just unmute and speak out. Anybody? So if there's no blood return, I've seen nurses just pull out and stick again. And it may not be that you're not in the port. It may just be that the patient has to turn their head and cough, or lift their arm, or just shift their body. If they're sitting up, you may want them to lay down, but don't automatically pull that needle out and re-stick them, because that might not be the issue, and it just causes unnecessary discomfort to the patient. Try repositioning the patient, try repositioning the way the needle is facing, and just try to do a flush, because sometimes just a little bit of a flush will then generate a blood return. So try all of that before you do need to re-stick. If the patient is experiencing pain on flushing, what do we do? Come on, guys, I know you know this. I can answer all my own questions, but that's no fun. Okay, if there's pain, then something is definitely not in position correctly. So you definitely want to find out what's going on there and then reposition that needle. Sometimes it's just a matter of pulling back a little bit, not all the way out, and then just trying to reinsert. So the last thing you want to do is pull that needle all the way out, because sometimes just moving it a tiny bit, it's like when you're trying to get a peripheral and you know you're very close to the vein and you just pull back and move it a little bit and you can access it. The same thing with the port. Sometimes you just may be too close to the side of it. Just pull back a little bit, push in a little bit different angle, and sometimes that's all that's needed to work. If the portacath has to remain in all week, we must do teaching and training for the patient, teach them how to keep the dressing dry and intact, teach them how to flush in between their infusions, teach them how to secure it. If they have to shower, or if they have activities or have to lift anything heavy, when you lift things, or when you're bending to pick up a child or walk a dog, believe it or not, you're using your pec muscles. So make sure the patient knows that anything they do that's lifting or moving or shifting their upper body, there could be a potential to dislodge that Huber needle. So please do all your teaching and training around their activities. Maximize patients' comfort at all times during the Huber needle maintenance, especially if it has to stay in for a week. Okay, I need 2 seconds here. Okay, I'm sorry, did somebody ask a question? Okay, so if we're not getting a consistent blood return, Jasmine, what do you think we should do if they're maybe getting a few drops and not really consistent? What would you do? You can unmute and just respond.
That's
flash,
Kim.
separate,
I'm sorry?
separate flash.
Good. Absolutely. Or repositioning them, have them turn, have
Mhm.
them lay down, have them cough, because that actually helps to relieve some of the pressure in their chest. And sometimes that's all that's needed too. So, good. Okay. Anybody have any other questions?
I don't know, can you
Yep.
hear me?
Yes.
Oh, okay, I thought you couldn't hear me. All right. Not now, later.
Okay. So, just like on the
One
PIC.
question.
Oh, absolutely.
Yes, talking about comfort for the patient during the
Yes.
change. You know, there are times that we get a call from a patient saying that the nurse came out and did the dressing change, mostly with PICC lines, PICC dressing change, and then let's say about an hour to 2 hours after the nurse leaves, the patient is complaining of
Mm.
pain at the site.
Mhm.
You know, and we'll have to, either the nurse has to go back or we'll look for somebody else to go back and redress it. So what can we say to that?
So first of all, we want to try to prevent that. So anytime before we leave a patient's home, regardless of what kind of IV line that they have, we want to make sure that everything is comfortable, have them move their arm if it's a peripheral. And we'll talk about peripheral lines in a minute as well. But make sure that everything is comfortable for them. They can change their tops. They can do all of their activities of daily living without any discomfort before you leave. If there's any discomfort, it could be that the tape was taped down too tight and it's tugging on the skin. It could be that that line is kinked, like we mentioned earlier, and I do have a picture of that coming up. It could be that the patient just maybe moved and did something and tugged on something. So all of these issues we have to find out. And unfortunately, there are times when having the patient shift or move or move position or do anything like that, if it doesn't relieve that discomfort, we do have to have a second visit, a nursing visit. And that's never good for the agency. That's never good for the patient because now they're frustrated and we've left them in pain. So please make sure to do all your teaching and training and teach them how not to dislodge that and make sure it's all comfortable before we leave. But there's no other way to prevent it. If it does happen, we do have to get in there with another nursing visit and reposition that line. Okay.
I want to share one case.
Absolutely.
My patient's arm after the PICC line insertion, there is the big bruising, like a big bruise there. Yeah, patient question on it, but there's nothing we can do. Blood retains good, and then later on after a week, so the bruise is like a resolved, you know. So I just want to share this case. Don't be scared, you know, the big bruise that could be like insert the side, you know, it's not the arm. You know, false. Yeah.
Absolutely. It's very common.
Share this case.
Absolutely. And the only thing we do want to make sure we teach the patient and we monitor ourselves. A lot of times because they're doing a cut down to access and to insert that PICC line, yes, the patient might bruise, especially if they're on blood thinners, but we have to teach the patient if that bruise gets bigger, if that bruise gets harder, if that bruise gets more painful, we do have to worry about, because what a bruise is, what a black and blue mark is, or a bruise, is blood seeping under the skin from that patient being accessed. And sometimes that blood seeping under the skin will clot, and we want to make sure that we're not getting a blood clot with this patient. So teaching and training is very important in that case. But yes, it does happen.
Okay.
Thank you for that. That makes sense. Okay, so just like on the PICC line, teaching and training is critical before we leave that house. If that portacath is staying in for a few days for an infusion, we want to teach and train and return demo everything that's necessary. Now, they're not going to be accessing their own ports necessarily, but we want to make sure that we do teach and train everything we're doing. So if they have any questions, they know what's been done and they know what to expect. So if they have to disconnect for any reason, if they're on a long-term IV, maybe 24 hours, which is not very common, but it has happened, then again, teach them how to use the alcohol swabs, teach them the Kuros caps if they're there. The safety clasps, how to open and lock them. SASH protocol, if they do have to start an IV line, then the medication themselves. Teach them about those pump connections, because if that pump beeps at 3 in the morning or 4 in the morning, that patient's not going to be a happy camper in the morning. So we want to troubleshoot with them all the reasons why it might beep, when to change the batteries, when to resume, when to repeat, how to pause the machine, how to turn it off if it's beeping until we can get there. A lot of patients don't even know how to turn off a pump. So we want to make sure that we're leaving them completely comfortable with the fact that if anything goes wrong, they at least have some answers of what could be causing it and then how to relieve that. And again, just like on the PICC line, be available by phone if they have to do an independent infusion for any reason, because you don't want that patient to start feeling that frustration or that aggravation and it's taking them too long, and then they have to finally find the number of the agency has to track you down. If they can't track you down, or if you're not available, they track me down. I have to do a video conference call with this patient. It's time lost and it's not good patient care service. So please just keep that in mind. If you're ever leaving a patient independent, make sure they have done that return demo and make sure they understand all of the issues that could go wrong and how to fix it before you leave, please. Thank you. Okay, let's talk about peripheral lines. First and foremost, listen to that patient. Most of our patients do know where their good vein is. And a lot of times the nurse doesn't listen to the patient because they have a preference where they want to go. But we have to do our best to use the patient's preferred site. And sometimes they're not even sure. So if they have a preferred site, ask them why. If it's an IV that you're just doing for 2 hours or 3 hours, it doesn't matter whether you used your site or their site. But if it's a line that's going to stay in for a few days, then we have to use the most practical site. We don't want to use, for instance, an AC if that's going to be in for 3 to 5 days, because that's going to interfere with them bending their arm, maybe showering if you're using their dominant arm, using the bathroom, picking up a baby or a pet or walking an animal. So you want to make sure that where you're choosing to go is in line and practical for what they have to do. Do they have to go to work? Do they have any responsibilities? Are they a caregiver? Do they have a caregiver? All of these are so important when you're choosing a site for an IV. Avoid the hairiest part of the arm, because otherwise the tape won't stick very well. Secure that appropriately so that it will not dislodge. A lot of times we leave a patient and we don't secure it well enough, and then boom, they've done one ADL or walked a dog and that line yanked out, or they went to cook something, that line was hanging and it got caught on something and that line is now out. So before we leave that patient, make sure it is secured appropriately and everything looks good and it's in a site where it will not interfere with the patient's ADLs or anything else that they have to deal with. Now, another issue that I get a lot of calls on is this patient's having a lot of trouble, or the caregiver's having a lot of trouble. The patient might be able to do it independently, but the nurse did not put an extension set on. So first and foremost, find out if this patient is capable of doing this IV line themselves, and please add an extension set in case they want to. Sometimes they're capable, but they may not want to. Put an extension set on anyway, because if that caregiver, a parent or a child or a friend that's supposed to be helping has any trouble, at least now the patient can help, even though they may not have wanted to, but at least give them the opportunity so that we don't have to send a nurse in just to do that first infusion because they had trouble. So remember, please put an extension set on. Okay. So questions. What is the best practice if the only visible vein we feel is in an inconvenient location? What would we do to help mitigate that issue? Anybody want to answer? I'm going to start calling. Whoops, I'm going to start calling on people. Okay, I don't know everybody's name. Some people don't have their name on their who's D. Ramos? You want to jump in
Hello.
with an answer here?
Yes, I am. Can you hear me?
Yes, now I can.
Okay. The best practice if the only visible vein we feel is an inconvenient position, I would say if this is just a one-time infusion that's only going to be a 2-hour type infusion, that we try our best to go with that one. If the other veins aren't, you aren't able to do it, or you just go with the antecubital, or you go with a vein that you can feel but maybe not see.
Mhm.
Does that sound good?
Absolutely. Absolutely. And what if it has to stay in for a few days?
Well, if it has to stay in for a few days, then I would go for something that you could feel but isn't visible. Just I would try to do something that I know where a vein usually is and go for that. Or
Perfect.
yeah.
Absolutely. So some things we can do, we can put heat to the area.
Yes.
What I do is I don't carry around hot packs, but we always have gloves. Fill a glove with hot water from the patient's sink. And
That's
if
what I do
it's
too. Yes.
excellent, and if it's not warm enough, you can always microwave it for about 10 or 15 seconds. Usually that helps. And these gloves can withstand that. So microwave it, have them hold on to the glove or put the glove on the arm where you know there should be a vein and you just don't feel it or see it yet. But have them put their fists down and pump so that gravity can help. And, try any trick that you can to
I used,
find a more, I'm sorry?
soup
No, go ahead.
cans, when you ask them to get a soup can under their cabinet and they can do some arm
Perfect.
curls for a couple of minutes, that can work too.
Perfect. Absolutely. I've even had patients drop and do 10 push-ups because
Yes.
that helps their veins. Now, not all of our patients can do that.
True.
But yeah, soup cans are great because then they can do those curls and that helps to pump up those veins. But heat is also phenomenal. A lot of
Yes.
people forget that we can just fill a glove with hot water and use that.
Yes. Or a heating pad if the patient has it.
Absolutely. Those don't get as hot and it takes a
True.
while to warm up. But yeah, if that's their only option, then absolutely. Because a lot of them don't like the gloves, or you may not have sometimes the pharmacies only send 2 pairs of gloves, one for starting, one for
Yes.
ending, and you may not have an extra glove. I try to always keep extras, but sometimes you run out. So absolutely a hot pack or a heating pad. Okay. Does everybody know on a pump what the up occlusion is for and what the down occlusion beeping is for? Is there anybody that is not sure what up occlusion or down occlusion means?
You can remind me.
Okay, up occlusion means there's an issue from the pump up the medication line. So between the medication bag and the pump, something is clamped or something is blocked. Down occlusion is from the pump down the line to the arm or the chest, wherever the IV site is, whether it's a port, a PIC, or a peripheral. So down from the pump or up from the pump. I went into a patient's home once. I was called because this nurse had 3 times changed an IV line and couldn't get the pump to stop beeping, and it was beeping up occlusion. So if it's beeping up occlusion, that issue is between the pump and above, maybe just the way it was inserted, the line was inserted, but it had nothing to do with changing the IV line. And now we put the patient through 3 sticks already for nothing because the site wasn't the issue, the location of the clog or the kink was above the pump. So please make sure you understand that before causing some undue stress to yourself and to the patient. Make sense for everybody?
It usually happens clamp, clamp up the.
Sometimes
in the
there's a
tubing.
kink, sometimes there's a kink in the line
Yeah, kink
above
or
the pump.
clamp. Clamp is, closed, so.
Right, it could be a closed clamp. If there's
Yeah.
one above, it could be a kink in the line. Yes.
Yeah, happens all the time, you know.
Yeah,
Clamp. Mhm.
absolutely.
Or
That's one of the
tubing
more
issues.
common. What?
Or the tubing issues, you know, because sometimes
Correct.
these pumps eats up all the tubings and they have high pressure, and that's what I watch
Yes.
before I check for anything. I just look at the pressure of it too, because once it goes up, it's gonna go down the line occlusion, you know.
Correct.
Well,
Absolutely. A lot of times, yeah, a lot of times it's something super simple. So please don't cause undue stress to you and the patient by trying to change their site when it may not be a site issue, an IV site issue. It could just be the pump is beeping, maybe it needs a new battery. I've had that happen too, believe it or not. It was beeping because it needed a new battery, and this nurse had to stick the patient numerous times and didn't look at the pump to see why it was beeping. She just thought there was a block. So again, please make sure you know why the pump is beeping and teach the patient, in case you're leaving with them, what the possible beeps could mean and what they need to do in those cases. Because maybe they just didn't open the clamp, or maybe they didn't put the tubing in correctly into the Curlin pump. So these things seem simple to us, but it's brand new to these patients, and they do need to be told what it means and then what to do for it. Okay. What's important to teach and train these patients when we do an IV line? So first, again, demo and return demo is absolutely critical. We want to make sure they're not only watching us and they're not only listening to us, but they're actually doing it for themselves before we walk out of that house on that start of care. They must know how to do that. You must watch them do that instead of just leaving them floundering and uncertain for their next first independent infusion. Teach them the SASH protocol, teach them how to check for patency, drawback, how to use the flushes. I got on a video conference call fairly recently, and the patient was having trouble flushing with saline, and she thought there was a clog in the line, but really the only problem was she didn't pull back and break that seal inside the saline syringe before pushing. Something so simple, teach them how to pull back and then release the air from the saline syringe before trying to push, because all that does is add pressure, and it seems like a clog, but they just didn't release that little safety mechanism inside the saline syringe. Teach them how to clamp, and even more importantly, how to unclamp when they do need to use that line. How to use the alcohol pads or Curo caps, whichever is included. Teach them how to prime that medication line. It's very important that they prime a line first. A lot of times these days, a lot of the bags are coming pre-primed, which is really nice, but not always. So please make sure the patient understands what that means and what they have to do to get all the air out of the line. Pump troubleshooting, again, what each beep means, what it means to resume versus repeat. And if any of you are not sure, please ask me, and how to pause and unpause that machine, or how to shut it off if it is beeping and they can't figure anything else out. Please review all these pump settings with that patient on their start of care. Don't try to save it for the next day, because you may not be available and another nurse may not be available to walk them through all of these steps. Again, answer all questions and concerns for the patient. And again, I can't stress this enough, so I'm going to repeat it. Make sure that wherever you're leaving this IV line, it's in a convenient spot for any of the activities that this patient needs to have their arm free for. Make sure that if they have to lift patients, lift children, or care for elderly patients, or lift parents, walk dogs, teach, maybe they're a teacher, maybe they have other careers where they need their arms available in certain spots or their hands available. Make sure you're putting this IV line in a place that's very convenient so that it has very little chance of pulling out of the location. Okay, let's talk about midlines. We're going to watch a quick video here.
Can I ask one question about flushing on peripheral IV?
Absolutely, absolutely.
A lot of my IVs are just a one-time, and they still ask for a SASH protocol. And I
Yes.
just feel the heparin isn't necessary if it's the next IV is in 6 weeks. Is
Mhm.
that okay to not do the heparin or just do it because it's ordered? Or, I mean, it's mostly for not clotting and seems like it's unnecessary for the patient to add that to them as well if they don't need it.
Right. Yeah. If it's just a one-time 2-hour antibiotic or
Yeah.
Ocrevus or something like that, yes, you don't have to. If you're pulling that line, you do not have to put in the heparin.
Yes. Okay. Thank you.
Thank you. Okay.
And clamping midline. So here's a midline. Normally, obviously, this bit's in the patient. You don't get to see this. But with the model, we can see how easily blood back to the line if we don't flush and clamp it properly. So if I unclamp the line and put my syringe on, already we can see blood coming back into the line. So we'll use the push-pause technique to flush. So a mill quickly and pause, a mill quickly and pause, mill quickly and pause, one more. And then into the last mill, keep the positive pressure on the end of the syringe and clamp the line with the other hand. So that when we remove the syringe, there's no blood in the line at all.
Okay, midlines work very,
Okay,
very
straight.
similarly to a regular peripheral line. It's just a little bit longer. And it's usually put in place for a couple of weeks, 2 to 4 weeks, as opposed to the 3 to 5 days for a regular peripheral line. So we do want to make sure that we're not putting in the midline. They usually come home from the hospital with the midline. All we're doing is changing that dressing every week for the 2 weeks or the 4 weeks. And we just want to make sure we secure it so that doesn't pull out. And we do want to make sure we're flushing that with the SASH protocol because that line does need to stay in for a little bit longer. Not as long as a PICC line, but definitely longer than a peripheral. These do tend to clog more easily, so please make sure you are ending with that heparin. Okay. Any questions on the midline itself right now?
What do we do if the midline is clogged?
Okay, good question. So just like on a PICC line or a port line, it may not be clogged, it just may be kinked, or it just may need to have the tape or the tegaderm loosened for a bit. So first we want to try all of those things. We want to check for placement. If we're not getting a drawback, can we infuse? Because just like earlier when I said it's just like a used straw. Sometimes you can push in, but you can't pull back. It's like a straw just kind of sucking in on itself. So make sure we can still infuse and make sure when we are infusing that we're not seeing any swelling in the line. Because if we can push, sometimes it's just because that line dislodged and now we're getting an infiltration. So be very careful. If none of those things work, we do need to get an order to start. Usually we have an order to start a peripheral if the midline doesn't work. But if we don't have one in their file, then we must call the agency, let them know that the midline stopped working, and we do need to change to a peripheral. And we'll just let the pharmacy know. Okay, any other questions?
Yes, on removing a midline, I
Mhm.
do have the patients lay flat so that, or recline at least as it's coming out, and to hold their breath, the same as with the PICC line. Is this what you also recommend for midline removal?
No, a
Is that-
midline's
no?
fairly short, so they don't have to lay down. It's just like taking out a peripheral. It's just a little bit longer, maybe 3 inches long instead
Okay.
of like your 1 inch. So they don't have to lay down. They don't have to hold their breath. You don't have to do anything different. It's just like taking out a peripheral line. Okay.
Okay.
The same things for the other IV teachings also goes for the midline. Make sure, again, especially if they are going to be doing independent infusions for their antibiotics, that you demo and return demo. I can't stress that enough. On your start of care, they need to show you that they or their caregiver are independent and able and willing and available, and they can do it themselves. Make sure they understand the SASH protocol, how to check for placement and patency, how to use those flushes, especially how to get the air out of the saline and heparin by pulling back and breaking that little seal, because not everybody knows that. Not all the saline and heparin syringes come with that seal. Some of the brands do, and so it's always better to pull back before you push up. How to clamp and unclamp, how to prime that medication line, how to connect it to the pump, and how to connect that pump to the IV line. Again, the troubleshooting, critical to teach them before you leave what the beeps mean and how to resume versus repeat, how to pause, how to shower with that line in, how to secure it. And again, just like always, be available for that first independent infusion or bag change. If you know that it's now noon and it's once every 24 hours, just tell them to please call you if they have any questions, or just to feel more comfortable. It's 5 minutes out of your time versus several hours of possible frustration for the patient and the agency trying to track you down or me down and getting back to the patient if they have any issues. Again, it goes back to customer service. We want to have the best customer service. We want our patients to just feel comfortable, that you're not just walking out of their house and leaving them and having them try to remember something, because they may say yes, yes, yes to everything you're doing, but by tomorrow they're going to forget, or they're just not going to feel as confident, because it is scary doing it for the first time, no matter what the IV site is. Okay. So teaching and training, we have to make sure we're teaching them how to store their medications properly, how to set up the medications, how to take it out of the fridge 30 to 60 minutes before they're going to infuse so that it's room temperature, how to troubleshoot the pump, how to troubleshoot the IV line for blocks, how to disconnect in between infusions if they want to shower or go out or do anything, how to maintain that IV line if they have any activities of daily living they need to be free for, how to reconnect, of course, how to take care of that line for hygiene, meaning if they need to shower or do anything else, how to protect that line, and teach them when to call the agency, when to call the nurse, when to call the pharmacy. Generally, they're going to call the agency first. That's usually what they have to do. But every now and then there are issues and they need to call the pharmacy. If it's 3 a.m, please have them call the pharmacy instead of the agency, or to track you down in the middle of the night. If that pump is beeping at night, please make sure they know the pharmacy number so they can call the pharmacy themselves and get a pharmacist on the phone to walk them through the issues. And of course, the pharmacy will let us know in the morning and we can follow up with them. But that's the easiest and quickest thing to do, okay? And again, most importantly, be available for your patient's first independent infusion. It takes 5 minutes out of your time rather than the several hours that the patient and the agency have to spend trying to fix the problem and the frustration. Okay, now there are some customer service policies I'd like to review with you, and I'm going to do it quickly because I see that we are running out of time. So practice excellent customer service. Oops, let me let somebody into the waiting room. Give me a second here. Okay. Okay, make sure you treat each patient with respect and dignity. We are a guest in their home. It's a privilege for us to be in their home, and we do want to provide excellent customer service. We've had nurses tell patients, "I know better, I'm the nurse." We've had nurses tell patients, "No, I'm going to do it my way." Just be respectful to the patient. If they want you to do something that is not in alignment with what's comfortable for you, ask them why and try to explain to them your reasoning for doing it differently. Sometimes it's just because they haven't been shown another way. I had a patient once call the agency and complain that I raised their IV pole and now they can't reach to hang up their sweater anymore. I mean, so we do get crazy calls, and it's just because the patient wasn't aware that the pole had to be raised to do the IV better and to get that gravity flowing. So just teach your patients so that they really understand what's going on if it has to be a different way. Anything else? please review this policy in your policy and procedures book. It is in your back office in your share file. Always observe infection control. Always walk into that patient's home, set your things down, and then wash your hands. Very important. And always keep that little bottle of the cleanse, the sanitizer hand cleanser with you. Patients are very aware that this is necessary for them. We see a lot of chronically ill patients, and a lot of them are pretty much aware that we need to be washing up. Even if you don't think they're the neatest or cleanest, we have to still be the neatest and cleanest when we're in their homes. So it just shows respect for the patient. Okay, make sure that we follow this. Report all issues to the office immediately. Anything out of the ordinary, even if it seems very minor, please report any issues to the agency so that we can take care of it. Some reportable issues, if you need to arrive late or if there's a missed visit for any reason. Patients not responding to confirm or to schedule. Missed labs for any reason if there's a missed lab. The lab not accepting a blood specimen due to insurance or other issues. Please also make sure you know how to draw the labs appropriately before you get to the patient's home, because sometimes it is too late to drop off a specimen, or we want to make sure we're going to the right lab and that their insurance will be accepted at Quest versus LabCorp or vice versa. Late delivery of supplies. Make sure before you go, your patient did receive their delivery. Checking on the medication. We'll talk more about this in a minute, but if there's the wrong medication, there's no medication there. I had a patient once call me and say, my supplies are here, everything's in the box, and I didn't open the box yet. I went and all the IV start supplies were there, but there was no medication. So we do have to make sure before we unpack anything and stick the patient, make sure that medication is there as well. Any adverse reactions, any malfunctioning of the pump or any other equipment. We have occasionally had bottles of medication not infused properly or tubing not working properly. It doesn't happen often, but it happens. So everything has to be reported, because if you're now using up their extra supplies, the pharmacy has to send more supplies. So please make sure that it is reported, because it could be a supply issue. Any questions so far?
No.
Okay, so
I
possible.
do have one.
Yep, go ahead.
A lot of people ask what they can do with all their extra supplies, and the pharmacy won't take them back, so I don't know what to tell them. Just throw them away.
Exactly, they can throw them away. I will sometimes take some extras because I like to have a stash of extra IV start kits and other things. It's always necessary, but check your expiration dates. So yes, I will sometimes take some. Sometimes I'll tell the patient save it, because if you know this is a chronic issue and they may need extra antibiotics in the future, if this is maybe their third time they're on antibiotics for their diabetic issues and they still have wounds and they're getting wound care, chances are they're going to need them next month or in 2 months or in 3 months. So tell them to hang on to them for a while. And sometimes they know somebody that they can donate them to. So that's also an option. But otherwise, if nobody needs them, they can just throw them out. Unfortunately, the pharmacies do waste money, but they do have to send extra supplies as well, so that we don't get stuck in the home not having enough supplies.
Sometimes, can I add?
Yes? Yep, go ahead.
Tell a pharmacy, do not say next time. There is enough supplies in stock at the patient's home. I tell a family member or pharmacy not to send those next supplies.
Correct.
Then
yes,
they didn't send. So I use up the leftover. It's extra work, but
Yeah, absolutely. Use the older ones first, but yes, let the agency know, let A+ know to please let the pharmacy know to stop sending the extra supplies for a while, just to send medication for the next visit or two. If
Yeah,
they're,
that works out. Yeah.
yeah, sometimes they'll still send it, we can't help that, but at least we can try
Right.
to save money.
Yeah. Sometimes they keep sending, and there's so much supplies. You
Exactly.
don't know what to do.
Yep. They unfortunately just have to throw them out.
Okay.
Many patients donate extra supplies to animal clinic. They accept that.
Correct. That's true. The animal clinics, the VFWs will sometimes take things, ambulance corps sometimes. But I know that's a lot of trouble and calls to go through, so a lot of people won't make all those calls, but at least they have options before throwing out. Okay, infiltration. We all should know what infiltration is when the medication is leaking out of the IV line into the surrounding tissue. This can cause a lot of problems for the patient. Sometimes it's just discomfort, but if it's a more invasive medication, like even Vanco can be very irritating under the skin and could cause a lot of issues. So please make sure if there's an infiltration, we change that dressing site and we change that IV insertion site. Signs and symptoms of infiltration: swelling, discomfort, burning, tightness, cool and blanching skin around the area. This can cause numbness, tingling, and loss of function. So this can be really serious. It can really cause compartment syndrome, which is very serious, and it can cause nerve damage. So please make sure if you have an infiltration, you know immediately. If you're leaving this patient's home, please make sure they understand the signs and symptoms and what to look for, and when to stop an IV and call the agency, or when to go to an ER. This is very critical that they know how to stop an infusion if they start to see any of these signs. So first and foremost, stop that infusion, remove the IV or the IV line, elevate the limb, apply a warm compress. What the warm compress does is it helps the patient absorb the fluids a lot faster instead of it sitting in the limb for that long. Check the patient's pulse, start a new line in a different location, preferably the other arm. You want to make sure that you're not using the infected arm or the arm where there's any inflammation, because you want that arm to heal and not have more damage to it. Document and report this to the agency immediately, because it's something that the doctor's going to need to know and the doctor's going to want to follow up on as well. Extravasation is leaking of vesicant drugs like Vanco into the surrounding tissue. And this is more serious because this can actually lead to loss of function and amputation if we don't take care of this immediately. Signs and symptoms: blanching, burning, discomfort, just like before, but it's more serious because it's a stronger medication that can do more damage in the skin. Blistering or skin sloughing is another sign. So when we see blistering or this redness, like in the photo here, we have to understand, is this from the medication leaking, or is this from the Tegaderm, or is this from the patient sweating under the bandage? So again, we have to make sure of all of these signs and symptoms before we just ask for the non-allergic Tegaderm. We have to make sure this is not what's happening to the patient. So coolness around the IV site is one important factor to get you to understand that there is medication in their skin and not in the IV site, as opposed to when the skin is just warm and they're having blisters and redness, it could be more of an allergic reaction to that Tegaderm. But cool skin around that site, there's fluid leaking, okay? Stop the IV line, notify the prescriber. Very urgent that they get care immediately. Elevate that extremity. Frequently assess motor function, sensory function, circulation. Record this, report this. It's very urgent because, again, this can lead to very significant damage to the patient if this happens. Okay, so report this immediately, not 2 hours later when you get home, but while you're still in the patient's home, report this. Phlebitis is another issue that could happen. It's an inflammation of the vein itself. It's not the fluid leaking, it's the actual vein being inflamed. It's associated with acidic or alkaline solutions that have a high osmolarity. Phlebitis can also occur as a result of vein trauma during the insertion or using an inappropriate IV catheter size. So if the patient has very small veins, but you're using a 20 or 22 gauge instead of the 24, that could damage the vein and that could cause phlebitis in that vein. Or if you leave that site in for too long and you're not changing it every 3 to 5 days, if you maybe want to wait till the 7-day or 10-day infusion is over and you didn't have time to go back to change that IV for the patient, that's very damaging. That could cause phlebitis, and we don't want to do that. So please, if you can't get back there to change that site, let the agency know somebody has to get there to change that site. Signs and symptoms now, instead of cooling, like in the first 2 symptoms, here you are seeing warmth in the area. Puffiness, warmth, redness, tenderness. There's sometimes that red line running up the arm, which is the infection already spreading. Okay, so all of these 3 things you need to not only be aware of yourself, but you need to teach and train the patient what to watch for when you're walking out of their house and now they're going to be alone for the next 7 days till you come to change their IV dressing. They need to know what the signs and symptoms are that they need to watch for. So just like the others, stop the infusion, apply warm, moist compresses, document, and notify immediately while you're still in the patient's home. The pharmacy might say start a new IV line. They may say hold off until we clear that up. So it's up to the pharmacy whether we start a new line or not. So please, the agency has to notify the pharmacy while we're still there and tell us what we need to do. Okay, let's go to some scenarios pretty quickly so we can get you all on your way. It'll just take another couple of minutes here. What is wrong with this dressing? Alberta, you want to call on somebody?
Okay. Brittany Lewis. Good morning, Brittany.
Good morning. Can you hear me?
Yes.
Good morning. It's not dated.
Okay, in the homes, if we're the only nurse going in, it's not like a hospital, so we usually don't have to date it in our homes, in the patient's homes. So the issue is, first of all,
upside down.
Patch.
yes, the bio patch is upside down. Good. I'm sorry, I can barely make out what you're saying.
Sorry, I'm at a coffee shop. I apologize. No, just that the bio patch was upside down, and I think that's it. The base was put on correctly.
The stat lock is on correctly, but look at the position of that. That's almost making a 180 turn in the patient's arm. So there's a very good chance that that is now kinked inside the patient's arm because of how much that PICC line has been turned and twisted. And the dressing, you see how tight that dressing is, that it's pulling the skin. So that's going to cause discomfort, possibly pain for the patient. Okay, good. Let's go to the next one. What is wrong with this dressing? Albert, I'll leave it up to you to call people. Oh, yep, go ahead.
No stat lock.
Correct. No stat lock, and look how much that's pulled out from the arm. So somebody left it, didn't document, didn't report, but that is not any longer in the right placement. Okay, so that's definitely an issue. Good. What is wrong with this dressing?
It's stained.
Yes, so we definitely need to do a dressing change on this patient, and we need to find out why is it leaking? Is that just day one that they came home with it like that? Or did they bang it? Did something happen to them? We have to figure out why it's bleeding and leaking like that. But definitely that needs to be changed. We cannot leave a patient's home with it looking like that. What is wrong with this?
It's a no, dressing coming off. We need to
Everything.
really good, and then we reapply the dressing.
Well, we can't reapply the dressing because look how out of place that PICC line is coiled up inside there. That is way out of place. That is very dislodged. That is probably very little bit left inside the skin and inside the vein.
It's an ER visit?
That's an ER visit, not because it's pulled out. We need to take that out and we need to send them now to an ER to get a new one placed. They don't need the ER for this one because that's pulled out.
Okay.
You just need to document, report, seal that up, pull it out, seal it up, let the agency who will let the pharmacy know that that PICC line was dislodged, pulled out, and they need to get a new one placed.
What if we do not have an order to pull the PICC? We've had instances like that where it's literally almost out. We don't have orders to pull the PICC. You call pharmacy and they said, you know what, send the patient to the emergency room. We don't have orders. And they try to reach the doctor and no response. We try, no response.
Yeah, then in that case, the emergency room will have to take it out. But more times yes than no, we will have an order that'll say pull PICC on completion of medication. And it's sometimes buried in the initial orders. If it's not there, sometimes if we call the pharmacy right away, we'll get a verbal order and they'll say, okay, pull it. It's got to be pulled anyway. But yes, we'll either get the verbal from the pharmacy or we can look and see if it's buried where the medication is ordered, see if that last line is there. Pull PICC on completion, and that's all we need. And that's considered a doctor's order to pull in this case as well. Okay, same thing with this dressing, it's pulled, but there's also those blisters and those skin irritations. So now, because you can actually see that it doesn't go up above, and I know on this patient in particular, it didn't go down below. This was specifically just under the tegaderm. Now we have to assess for infiltration, extravasation, or phlebitis. It's not phlebitis. That would be one of the first two. We have to see if this is a medication reaction. We have to see if it's an infiltration or an extravasation by feeling the arm. Is it boggy? Is it cool to the touch? Is it anywhere else on the body, meaning it would be a medication issue? Or is it just because they're allergic to the ChloraPrep or alcohol? And then we have to change whatever we did last time and try whatever we didn't use last time. If we used alcohol, now we have to use ChloraPrep. If we used ChloraPrep, chances are they're going to be allergic to that. That's more common than the tegaderm. So if we've used ChloraPrep, now we have to use the alcohol and the iodine and see if that starts to clear up. And if it doesn't clear up, then we have to have the pharmacy send the non-allergic tegaderm. Makes sense for everybody?
Yep.
Okay. What's going on here with this dressing?
Oh, it looks like all pulled out something.
Or not.
No covering.
It's pulled out and it looks like either the patient cut the line or the nurse, when she was trying to take off the dressing, for some reason the line is cut. The line is no longer attached. Again, this is a huge infection issue. We need to pull that ASAP and not just send the patient to the ER. We have to try to tell the pharmacist this needs to be pulled immediately and try to get that verbal if it's not in the chart, because that's an open line going right into the patient's large vein, the vena cava. We don't want to leave that exposed like that. Okay, so if the patient is on blood thinners, what are your thoughts? Should we still flush their line with heparin? Anybody have a thought?
Yes.
Yes, I would.
Absolutely, because there's not enough heparin in that syringe to interfere. It's just enough that we need to keep that line patent. So yes, they still need that heparin injection. If that was ordered by the doctor in the pharmacy, we still have to use that. Yes.
Yeah, it's small dose.
Absolutely. And let the patient know too, if they have a question about that, just let them know it's only enough to keep that line patent. It's not enough to interfere with their bleeding times in any way. This I know we've discussed. We're going to skip that just to save time. If a patient calls the office to report loose IV dressings and requires multiple visits in a week for their port or PICC dressing, what can we do to help prevent this? What are some things we can do?
Oh, I would say, reinforce dressing area.
Correct. We can reinforce it. We do need to go and change it. If it's somebody that sweats a lot, we may have to go twice a week. If it's somebody that's just wetting it over and over in their shower, we have to do some teaching and training. So for whatever reason that it's loose, if it's a site that's very hairy, maybe we can have the patient shave their arm when we come before putting on the clean dressing. So there are things that we can do to help prevent that, but we do need to go out and change that. So if a patient calls you, don't just automatically have them reinforce it if you're not going to get there for a few days. We do need to go out, let the agency know they need a visit, but we need to do the teaching and training so that we can prevent this from happening again. Okay, this I know we talked about. If the patient says there's extreme itchiness or has a rash or redness at the site, again, we have to figure out why before we can figure out what to do about it. And we have to make a visit to that patient because it could be a medication issue. It could be the tegaderm issue. It could be the extravasation. It could be phlebitis. It could be any number of things. So we don't want to tell the patient, when I come next week, we'll figure it out. Nope, we've got to figure it out right now so that we can stop any major issues from happening. If the patient tells the nurse there's pain at the infusion site, what are some reasons this could be caused by, and what can we do to alleviate the pain?
Can be an infiltration question.
Correct. Correct. Could be an infiltration. It could be that line was tugged and pulled, maybe doing that 180-degree turn like we had in that one picture. It could be taped down to a point where it's actually pulling on the skin. So if there's pain, we do need to make a visit and we need to figure out, do we just have to loosen the tape or the tegaderm? Is there pain because there are blisters? Is there pain because there's an infiltration? We need to find out all of these reasons and take care of it and prevent it from happening again. Okay, very, very important. What must the nurse check when starting a patient on any IV medication to avoid any errors? What are the checks and balances we need to do when we get to a patient's home? And a few of you can answer.
What is the nurse check?
Check the label, right patient, right name, right date, right?
Absolutely. We want to make sure that the medication bag has the right patient's name on it. We want to make sure that the medication has the right dose on it. We want to make sure whether this is a medication bag that's a 24-hour bag, or do we have to teach the patient how to change it twice a day or 3 times a day? Is it a full bag for 24 hours? Is it one dose that's going to infuse over 1 hour every 24 hours or every 12 hours? So are we teaching the patient once a day or twice a day? Right patient, right dose, right time. all those other rights for the medications. We want to make sure that the doctor's order matches the pharmacy order and also matches what you have in the home. Because sometimes the pharmacy will send what the doctor ordered or think they're sending what the doctor ordered, but it has a different patient's name or a different dose or a different Q24 versus Q12. So we want to check all of that information and make sure everything is accurate before we give any medication to any patient.
Especially, you know what, I caught an error from pharmacy, and there was the easy pump, you know, the automatic pump or the pump.
Yeah.
The patient's getting vancomycin via the easy pump, and they wanted at like maybe 100 ml per hour, and they put 250 on there. So you got to check that little button
Absolutely.
because it could go so fast, and that could harm the patient. So, and I just want to pass that along because it's easy to do, easy to miss, you know.
Absolutely correct. Thank you for that. Yes, we have to check everything. We don't want to ever assume that it must be right because the pharmacy sent it. We have to check this. Thank you. Okay, last is these policies and procedures for all your IV therapies are in your share file. Please make sure that you go through all of these policies. For instance, 1-110 is for your IV site dressings. And I know we talked about that today. Please go and read it in your policies and procedures book and make sure that you are really knowledgeable, because sometimes things change, sometimes things are different. Sometimes there are errors in the home. Sometimes we don't have the supplies that we need. So please make sure you're fully aware of all these policies and procedures. Now, drawing blood. When you're drawing blood, please make sure you're following the proper policies and procedures, and make sure you have an order that you can draw from the PICC, from the port, or from the peripheral. Sometimes the doctor will specifically say, do not draw from that line. So we have to make sure that when we're going out, we don't just check what orders are needed, what labs are needed. We want to make sure that we're able to draw from the line, or do we have to use another IV site to draw labs? That's just as important as getting the lab. Also, make sure you discard from whatever site you're using. If we're drawing from the PICC, the port, or a peripheral site, we want to make sure that we waste the 7 to 10 mLs. And we want to make sure that we're drawing up the blood the right way in the right tubes. If you're not sure what tubes to use, please get with the pharmacy, with the agency to get with the pharmacy before you get to the patient's home, so that you're completely aware of what lab it has to go to, what tubes you have to use, how many tubes you need. Make sure you're well aware of everything so that we look very competent and comfortable when we're getting to that patient's home, so that there's no guesswork. Make sure you put that waste tube into their sharps container and not into the lab bag with all the rest of the blood draws that you just drew, because that has to be wasted. We don't want to mix that up with any tube of blood that we're going to send for testing, because it will have very skewed results. Okay, make sure that we're doing the teaching and training for the patients as well when we're coming to do any lab work. Let's see, policies and procedures on PICC lines. Again, we did discuss all of this. All of these policies on procedures are in your share file. PICC line removal, make sure we do have a doctor's order. Make sure that the order is intact. Make sure that we are at the end of the line. Sometimes the doctor will say remove after last infusion, but sometimes they'll say draw labs before removing that PICC line. So make sure we're aware, can we pull it yet, or do we have to wait for a lab result to come in? Because sometimes the doctor may have to order another week or two of antibiotic before we pull that PICC line. So just make sure that we have all the right orders in place. Okay, Now, questions, concerns, and queries. Are there any incidents or issues that you have found that we didn't discuss that anybody wants to bring up now that we can talk about what happened and how we can make that better next time?
Okay, I have a question about the shop container. So the most patient ask where can send the shop container. So can you give us guide?
Absolutely. Generally, the pharmacy will say put it back in the box it came in. There's usually a return shipping label in there. If not, they will send a shipping return label when they send a new Sharps container. So if you see it's starting to get full, let the agency know immediately so that the pharmacy can send one on the next delivery. And then the patient can send that one back.
Okay, the pharmacy will send the return label.
Yes.
Okay, got it.
Yes. Perfect. Anything else? Any questions? Any issues somebody has come across?
Yes, I have one question.
Okay.
One of the patient had midline.
Yes.
So when I visit this patient and the midline was plugged. So I attempt a few times, then still unsuccessful. So I sent this patient to the ER. So they unplugged. So I was able to do next day IV infusion. So what's the difference? I do with heparin flush at home. Then ER, they have the stronger heparin flush. They flush the line.
Okay, for a midline, we don't have to send a patient to the ER. We can
Maybe
just
PICC line then.
For a PICC line, yes. For a PICC line, we don't have to send them to the ER necessarily. That's up to the pharmacy. If they can overnight a cath flow, then we can do the cath flow in the home. We don't really want to ask a patient to go. It's going to be 6, 7, 8 hours that they might be in the ER. Sometimes they even have to, they're told they have to go back. It's a big, long, drawn out process to send them to the ER. So we try to avoid that. If
That's what they wanted. Because I called pharmacy. Pharmacy said it's gonna take 2 days to unplug the medication. Then this patient need, fungus medication. Really need continuously few days. So patients up to go ER. That's what happened.
Okay.
It will take 2 days to do the, procedure.
I think that for this case, we consider midline is the peripheral IV. So maybe you can restart the peripheral IV just for the medication,
Correct. Absolutely. We don't have to send to the ER if it indeed is just a midline. We just let the pharmacy know and make sure that they give us the verbal okay to start a peripheral line. Correct.
Obviously, he did not have access for peripheral foresight. That's the case.
So again, there are going to be exceptions to every rule and every protocol. Sometimes we can get another nurse out there to see if we can get a patient's access. It would be up to the pharmacy. If the pharmacy says automatically just send them to the ER because we don't want them to wait the 2 days, that's different. But if the pharmacy says, go ahead and start a peripheral, if you can't do it, have another nurse, have the agency send another nurse to try to get the peripheral first before we send a patient to the ER. We try to avoid them having to go to the ER if possible, but it's not always possible.
Also, another question, when you flush the line, how many times can you attempt? I don't want to force this line, but I can attempt a few times, common sense.
Right. Well, first thing you want to do is make sure it's just not taped down too tight. You want to try to reposition it without taking it out. Maybe do a dressing change and make sure it's not the line itself that's kinked. And then, of course, you try to flush it. You try to pull back. If nothing is working, let the agency know, let the pharmacy know, and see if we can get a verbal to do a peripheral before sending them to the ER.
Okay.
Thank you. Anybody else have any questions or any concerns or any issues that we didn't discuss that has maybe happened to you in the home?
I do have a question. This is Brittany. So I've been going into a lot of the homes, and I know you said if you're the only nurse going in, you don't have to label a dressing. But I'm noticing, at least with A+, we're not the only nurses going in. So why would we not date a dressing change?
Correct. I mean, there's nothing wrong with dating it. It's not 100% critical, but absolutely, if you want to date it and you're used to dating it, there's nothing wrong with dating it. It's just that if people don't date it, it's not a critical issue. Because if you're documenting that you changed it last Monday and now it's Thursday and another nurse is going in because there was maybe a patient complaint and you weren't available, if another nurse goes in, all they have to say is, when was this changed? If the patient doesn't remember, we just call the agency. But yeah, there's nothing wrong with labeling it. Absolutely.
Yes, in adding to that, sometimes we do have people doing a lot of PRN visits to change lines, or maybe even the original nurse who started it will go in on a weekly basis, but the nurse may go out on vacation and somebody else might take over the case. So if we date it, I think it's better, just so the other nurse will know. Sometimes you even ask the original nurse and they can't tell you when they changed it. They forgot already. You know, so yeah, just put it in place just in case, because you may not be the only nurse seeing the patient.
Correct.
It just seems like that would be best practice for all of us.
Absolutely. Makes sense. Anything else? Any other questions, issues? Any review of any specific issue that somebody wants clarification on?
I have a question on this. We've had a couple of calls whereby a nurse does a dressing change and the patient wants to disconnect, or maybe a nurse hooks up the IV, the patient wants to disconnect and is too tightly screwed on, and the patient cannot just get it out. So what do we do in such a case?
And we've had this happen several times. Please make sure before you leave the patient's home that they know how to unscrew that. We've had patients unscrew off that clave connector and now they're left with an exposed line that's not protected by a clave connector because they couldn't separate that connector. So please make sure that they can loosen it and unscrew that, and they know where to unscrew it from before you leave. If they're calling and they absolutely can't do it, maybe they can get a family member or a neighbor to help them. We try to troubleshoot on the phone as best as we can before we try to send another nurse, but at the very last option, if they can't do that or anybody can't do that for them, we do have to send another nurse to just unscrew that, because sometimes they do get screwed in tightly, and sometimes the patient accidentally twists it the wrong way and tightens it, not realizing that they're going left instead of right or right instead of left. And it's just, again, it's a teaching issue, and we just have to make sure that they're well aware of how to disconnect before you leave the house, and that it is capable of disconnecting before you leave the house. That's a way to prevent it from next time.